Please join me in welcoming Dr. Baratta and Dr. Dialing.
All right, so I am going to give the other perspective, really talking about why neuraxial anesthesia may be beneficial in patients undergoing both hip fractures and elective total hip replacement. I don't have any disclosures, but I guess one disclosure would be that I just really do love neuraxial anesthesia. It's in general my preferred technique. So I'm going to try to kind of present some opinions where it might be the better option. So there's a lot of historical data. This is the ICAROS group. It's the International Consensus on Anesthesia-Related Outcomes After Surgery. Stavros Mepsudis has done a lot of research in this area. And while some of this data is a little bit older, 2014 and 2019, they did have decent evidence to suggest neuraxial was better than general when talking about total joint replacement. And this evidence was a lot stronger in those patients getting total hip replacement. It was a very large review, and they found that neuraxial lowered incidence of major complications, length of stay in all patients, with the largest effect on our elderly patients and those with comorbidities. So even when talking about length of stay, getting our elderly patients out of the hospital sooner is really important, decreases the risk of delirium, postoperative cognitive dysfunction, and decreases the likelihood that they'll end up in a long-term assisted care. So historically, we've believed that neuraxial is better than general when you're talking about patients undergoing hip surgery. Similarly, this is just showing some of the data, and we can see many of these outcomes are all significant. They divided up in age range too, so you can see less than 65, 65 to 74, and 75 and older. And really all of them were significantly beneficial with neuraxial, except for just cardiac complications in those patients that were less than 65, but otherwise really decreased all significant complications when patients had neuraxial, so it seemed protective. And that was kind of what we went off of for years. Well, neuraxial is a better option for these patients. This was a recent article where they took a bunch of patients, about 40,000 patients that were having actually hip fracture surgery. So, hip fracture is something that's been looked at a lot because these patients are often very sick. They have, as Dr. Dealey mentioned, a high risk of mortality within, a year. They very likely don't return to home, may end up in long-term assisted care. They often do not return to being able to walk and do their ADLs. So looking at, is anesthesia somehow protective? So the good thing about this study is it was a large study, and then it was retrospective, but then they propensity matched patients. So here you can see where they bolded the results as what was significant. So the operative time, significant, but really not much different. Interestingly, the hospital length of stay was lower in the general group, but you could see combined stroke MI death rate was lower with neuraxial, as well as incidence of acute renal failure and incidence of DVT as well. So in this matched cohort, it did suggest that neuraxial has some protective outcomes in hip fracture surgery. But the one thing that did look at, when they broke it down on different ASA statuses, the most significant difference and the most benefit with neuraxial was in our ASA 4 patients. So our patients that are sick are most at risk for significant complications. So this indicated it could be protective. Now I want to mention the Newman study, which is the REGAIN trial that Dr. Dealing mentioned. And this is a great study because it was our RCT, took place across multiple institutions. The outcome was really interesting, looking at death, their just inability to walk, also looking at the number of patients that were able to go home versus into long-term care, as well as delirium and postoperative cognitive dysfunction. Now, we were a participating site because the original, the primary site was just down the road from us at University of Pennsylvania, so we were enrolling patients at our institution. So participating in the study, I know some of the things that were happening in it. I think it's a great study. It was a really hard study to do. And they did find, just looking at the data, no differences in outcomes, complications, disposition, or time to ambulation. However, I think there's some things you have to kind of dig deeper and look at the study, because there are flaws. One of the things that they did was they included patients 50 years and older. So if you think most of our geriatric patients we consider 65 and older, most likely the sicker patients, including that younger age group may have skewed how sick and frail these patients might have been. They also, and you broke it down, only about 25% were older than 85. So again, you may have missed out on a significant amount of our sicker patients. The other thing that was, kind of something that we kind of missed out on in the study is because they were looking at the ability to walk after the surgery, they had to be able to walk before the surgery. So they excluded any patients that really had poor functional status, weren't able to walk on their own, without a walker or anything like that. So missing out again on those patients that are sicker that we may need to really look at, is there an anesthetic choice that's protective for them? The other thing that was slightly problematic was there was no standardization of the sedation. So, we can do a neuraxial anesthetic, but if you're giving, high doses of propofol, you're almost doing a general along with your neuraxial. So are you really going to see the benefit of the neuraxial technique, because you're basically, sedating them with, almost a general anesthetic as well. So, a lot of the patients got, almost half the patients got midazolam, which obviously we all know can be very risky in our geriatric patients and increase the risk of delirium or cognitive dysfunction. About a quarter got ketamine. So without any standardization of sedation, we got to kind of look at these results a little more closely. The other thing was, when the study was going on, it was at the point where we were really kind of starting to do peripheral nerve blocks for hip fracture patients. So where, the evidence was starting to come out that, doing a block for these patients, a Baratta AOCA, femoral nerve block, or something like that, right when these hip fracture patients arrive in the hospital, can help decrease opioid use, improve analgesia, decrease delirium. So it was very inconsistent use across all the sites because it was so early in that period before we got some of the Cochrane data and all the reviews that really strongly recommend peripheral nerve blocks in patients getting hip fracture surgery or that present to the hospital with hip fracture. So without that and the inconsistent use, it could have skewed the results, because we know that the nerve blocks, can reduce cognitive impairment, can reduce the risk of pneumonia, can improve mobilization, decrease overall opioid use. So there are some problems with the study, and although it's a great study, I think, it's not something that, we need more data. And I will mention the RAGA trial that Dr. Dealing mentioned. And again, really didn't find any difference when they were looking at postoperative delirium. They did of note, so you can see that it was a significant decrease in intraoperative hypotension with neuraxial anesthesia compared to general. So, in many patients, hypotension can be a significant risk, so that is beneficial. But when we were looking at specifically post-op delirium, if you look at the very top line, where they look at the incidence of post-op delirium, you can see the incidence is 6% for the neuraxial and 5% in general. Now, this study did take place in China, and things are different there, how they handle patients and how they approach post-operative cognitive dysfunction in the hospital. And so the incidence were in the US, we're looking at more of an incidence of delirium in these patients, more like 20, 30, 40%. It's kind of a range, but significantly higher than they found in this study. And things that they do, and they mention in this study, in China, it's very normal for the family to be very involved. Family are at bedside. They give the family lots of tasks to do to help their loved ones in the hospital to decrease the risk of delirium. So all those proactive steps that aren't as common here in the US and how we practice may, again, skewed these results because the incidence of delirium was just so low across both groups that don't compare to really what we have as a national average. And here they actually was a small study. It was a single-blind, non-randomized controlled trial, and they looked at general versus neuraxial and post-op delirium and early cognitive dysfunction, and they used the mini-mental status and the Wechsler test before and after surgery. And you can see that the neuraxial was really quite consistent, the orange line there, and there was really no change and didn't really have a significant incidence of delirium. But you can see that with the blue line with general, there was a lot more delirium in these patients. And about 30% of the patients that had general had some aspect of delirium, or only a little less than 5% with the neuraxial patients. So there are some studies that, like this, that do suggest that neuraxial could be protective. But again, I think remembering that has to come down to just neuraxial and really limiting any of your sedation. This was another study looking at general versus neuraxial. It was a propensity match study looking at the NSQIP data. And they found no difference in mortality, but they did, as I highlighted, find out lots of different other complications that neuraxial provided beneficial. So more patients were discharged to home or had any complication, less likely to be reintubated or on a ventilator, less likely to get transfusion, DVT, less likely to have an unplanned admission or be readmitted. So overall, the odds of complication were about 20% lower neuraxial. So there is evidence that it is still protective, even in our more recent literature. Now, I know a lot of people will be concerned, especially on our patients with hip fracture, that oftentimes they may be on anticoagulation, so it's going to prohibit our use of neuraxial anesthesia in these patients, given that, as Dr. Daly mentioned, most times a hip fracture, they want to get into the OR in less than 48 hours. But I will say, if you haven't looked at the most recent neuraxial guidelines or looked at the ASRA COAGS app, they just released updated guidelines in February of this year, and there were a lot of changes. The key changes were for the direct oral anticoagulants. Sorry. And the key, they divided the recommendations up into low or high dose. And with that low and high dose recommendations, they decreased the interval. Whereas the interval was commonly 48 to 72 hours, for many of them, if they're on low dose, it may be down as low as 24 to 36 hours. Apologize, I was getting over a cold this week, so I have a bit of a cough. They also recommend the ability to do anti-factor 10A testing to see if even in the time they've been off of it, their levels have normalized, and neuraxial may be appropriate. And that test actually is a fairly quick test that you can get. So with these recommendations, it makes it more feasible to do neuraxial, and likely that the patients have had enough time to recover from especially the DOACs. There weren't other changes in any of the other recommendations, really. I won't talk about it very much, but there is a lot of data with revision arthroplasty that neuraxial reduces delirium, transfusion, need for ICU admission, re-op, revision, length of stay, readmission, and blood loss as well. So, while I won't go into in detail, data does suggest that neuraxial is likely protective with patients getting total joint revisions. So I want to switch gears, also talk about total ambulatory total hip. I think it's a hot topic and a lot of efforts going into getting patients out of the hospital earlier, so to overall decrease healthcare costs, but will also not compromising outcomes. So can we, looking at that literature, give us more idea of any benefits of neuraxial? So we know that joint replacements have evolved over the years, and a lot of things have changed. So there's improved rehab and recovery, improved VTE prophylaxis, multimodal analgesia, using TXA a lot. With all of those things, it's enabled patients to get out of the hospital quicker with few complications. So we're just doing a better job at getting our patients ready to get out of the hospital. So this was just an older systematic review, and not specifically looking at ambulatory hip replacement surgery. So kind of before a lot of the TXA and the aggressive multimodal and everything that we do now. But earlier, this data would suggest that neuraxial was beneficial. But looking at some more recent data, this one's still a little bit older, but the only thing that this one found was an improvement in length of stay because of neuraxial. So in these patients with elective total joint, it may not be as protective as it could be for our hip fracture patients that are sicker. This was the YAP study that Dr. Dealing did mention, but they didn't find any difference in 30-day major complications. I do want to point out, though, that the study is vastly lopsided, because about 10,000 patients had neuraxial and only about 1,500 had general anesthesia. So it's not a great study as far as a multi-centered cohort study, very unbalanced. So even though there was no difference in 30-day complications, and as she did mention, as expected, your intraoperative and your PACU opioid usage and pain scores will be lower in your neuraxial group. The PACU length of stay was lower in your general group, but the overall likelihood of being admitted after surgery was lower in your neuraxial group. So more of the patients with neuraxial anesthesia went home. But again, it wasn't, it was a great review. So looking at, and there wasn't standardization as far as what local anesthetic you're using as far as neuraxial anesthesia. So now as we move to ambulatory joints, looking at more our shorter acting local anesthetics, does that change some of the outcomes? So this was a nice study. It was smaller, but it compared bupivacaine, mepivacaine, and general in both total hip and total knee. And you can see that while bupivacaine, as Dr. Dealing mentioned, some of the issues with neuraxial anesthesia, especially urinary retention, can be a concern and can often result in patients failing same-day discharge. But when you're comparing and using mepivacaine, much shorter acting local anesthetic, you can really negate those outcomes. So you can see when you're looking at a lot of the outcomes here, when you look at mepivacaine in general, we look at time to urination, actually was really lower in our mepivacaine group, so it really kind of absolved that risk of poor. Time to ambulation and mepivacaine in general were about the same, so it wasn't holding up patients doing physical therapy to get out of the hospital. But PONV, similar between bupivacaine and mepivacaine, were both about half that of general anesthesia. Time in PACU, total facility time, were very similar when using mepivacaine in general compared to your bupivacaine, which obviously is going to last longer. So as we move to the ambulatory total hip replacement, using our shorter acting local anesthetics can move that neuraxial into being about either as good or often more beneficial than general anesthesia. The other thing I want to mention is kind of parallel processing, or if you have a block room, how that can really skew towards proving neuraxial is beneficial. There's a number of studies, this is one of them, where it was a systematic review where they looked at does having a block room improve throughput. So it did decrease anesthesia control time by about 10 minutes, total OR time by about 16 minutes, PACU time by about 26 minutes. So then increase by using, doing your neuraxial anesthetic outside the OR in a block room while they're turning over the room, cleaning the room before you go into the operating room. It can increase in your ability to do about 1.7 cases per day. So doing more cases or ending the day shorter, not relying on overtime, is always beneficial to the hospital, decreasing overall costs of care. And so similarly, this was another study looking at the use of some sort of block room. So time to incision, about 5 minutes faster, improved first case start time, lower conversion to general, and no adverse events. And about this worked out to, if a surgeon was working in 1 OR, it increased about 2.2 cases per day. Or if they were across 2 ORs, it increased about 4.9 cases per day. So if that's something that works for you, doing neuraxial can just improve your throughput if you have that space to enable that to occur. And that can make your surgeons and your hospital much happier. This is just a review we did, but really just kind of looking at the comparison with ambulatory total joint and outcomes and what the evidence favors. Obviously with neuraxial anesthesia, the early postoperative pain, patients are not going to have as much pain in the early PACU time, but they may have some more kind of rebound late pain. So that late pain is in favor of general. PONV, neuraxial is usually typically protective of that. Less patients are going to be PONV. Urinary retention, the evidence, historically, especially with the large use of, isobaric or hyperbaric bupivacaine, urinary retention occurs less in general anesthesia patients, but patients getting ready for same-day discharge readiness, most likely they're going to be more successful in getting discharged home with neuraxial anesthesia. But otherwise, overall complications are fairly equivocal. So the ERAS Society recently kind of did a consensus statement on perioperative care for total hip replacement, and they really say that modern general anesthesia and neuraxial techniques may both be used as part of a multimodal anesthetic regimen. So a lot of the data does suggest they're probably fairly equivocal. This was just a nice study I pulled out about carbon footprint, because obviously we do create a lot of waste with anesthesia. And interestingly, I was kind of impressed because I would have thought neuraxial would have been less of a carbon footprint, but you can see in the red that, that is general anesthesia. So slightly lower, not too much lower than neuraxial anesthesia, but could create a lot less waste. But one thing to remember, again, when we're doing neuraxial, we should really just minimize and not make it a combined general and neuraxial. So I just want to mention, because I mentioned before, local anesthetic choice. So mepivacaine, chloroprocaine, bupivacaine. So I just want to talk about a little bit more about the local anesthetic and how that affects outcomes. So there's lots of studies that have gone into mepivacaine versus bupivacaine. So I highlighted some of them here. Especially looking at motor function with mepivacaine, motor function returning at 185 minutes versus 210 minutes, so saving about 25 minutes, which can be significant in the PACU. 1% compared to 11% had function return over 5 hours. So patients in the bupivacaine group were about 10% of them had a really long spinal. And one concern with mepivacaine would be TNS. The incidence is very low in most of these studies now where we would be concerned about TNS with mepivacaine does not occur at a high rate or any difference really than bupivacaine. The urinary retention and hypotension were similar in that study. Similarly, another study, again, motor function, about 50 minutes faster return with mepivacaine. Similarly with the time to the straight leg race as done by physical therapy. Mepivacaine decreased urinary retention, decreased time to discharge readiness, but they get, as expected with a spinal that's going to wear off earlier, the patients did have a little bit of increased pain, so they often need a little bit more opioids, but unlikely to be clinically significant. So overall, mepivacaine probably shows an earlier motor function, shorter length of stay, decreased urinary retention. So as we move to ambulatory total joint, choice of local anesthetics is very important. This was a RCT that we did at our institution where we compared mepivacaine versus isobaric bupivacaine and hyperbaric bupivacaine. And we're looking at percent of patients that ambulated within that 3 to 3.5 hour mark. And you can see here in the red column, about 70% of the patients that received mepivacaine ambulated, about 37% of the hyperbaric, and only 17% of the isobaric bupivacaine patients. So a good choice of local anesthetic for ambulatory total joint replacement. This was time to return of motor function, and you can see as well, again, the fastest return of motor function was in the mepivacaine group. As far as same-day discharge, we can see the percentage of patients, with using mepivacaine almost doubles the likelihood of patients having this actual same-day discharge home after surgery. Again, beneficial by decreasing costs and getting patients out of the hospital sooner. And the other thing that we looked at was muscle tension. So the surgeons were blinded to what local anesthetic the patient got, and we asked them to judge the muscle tension and how much the relaxation and their ability to do surgery. So one thing that was noted that some the surgeons did think that mepivacaine, the patients may not have been relaxed to their liking for the surgery. So it is something to consider. So not all surgeons may not like the surgical conditions. This was another one, mepivacaine versus bupivacaine. And you can see as far as no change in pre-op or OR, but you can see decreased time in the PACU, decreased total time for surgery, decreased time to ambulation, decreased time by almost 2 hours to void. Actually, the only incidences of TNS were actually in the bupivacaine group, And they did have slightly more oral morphine equivalents in the hospital, but 7.8 versus 3.7, not clinically significant. I think mentioning chloroprocaine, similarly, this is a forest plot just showing a lot of studies that were pulled out that just says that chloroprocaine, again, is beneficial in, having patients ambulate and get out of the hospital when compared to a low-dose bupivacaine, which is only 10 milligrams or less. So chloroprocaine, bupivacaine, very positive outcomes when talking about total ambulatory hip replacement. And again, this was another review where chloroprocaine was predictive, having shorter hospital stay, shorter operative time, because in general, if you're using chloroprocaine, it's a much shorter local anesthetic. Your neuraxial is not going to last as long, so your surgeons most likely either need to be fast or they got to operate faster. EBL was lower. PACU length of stay was decreased by almost an hour, and intra-op hypotension was significantly reduced with the use of chloroprocaine. So a lot of options, and a lot of this data can be also applied to our elderly hip fracture patients with neuraxial, using bupivacaine that will decrease hypotension, decrease duration, increase their motor function, can all be beneficial. So I would argue that I've kind of countered a lot of what Dr. Dealing said, and neuraxial is better, as being from Philadelphia, Rocky at the top of the art museum steps would say. But in reality, the choice of neuraxial versus general anesthesia, it's still quite similar, and it's really going to be based on institutional, patient, surgeon, anesthesia preferences. In the institution, it may depend. Do you have block rooms? How big is your PACU? Because if you have patients that are, still have a motor block from neuraxial and they're sitting in the PACU for longer, taking up spaces, all of these things can affect what works for your institution. Obviously, what the skill level of your individuals in your department are with neuraxial. The surgeon comfort, case duration, how fast are they at operating can affect your choice. Do you have short-acting local anesthetic available? And the overall ability to manage anesthesia-related adverse events, the potential for poor urinary retention with neuraxial versus PONV with general. So in summary, neuraxial may still confer benefits, especially in hip fracture surgery, and it might still be beneficial in our sickest, most at-risk patients, especially when talking about cognitive dysfunction and delirium. In ambulatory total hip, may improve throughput and improve discharge readiness for actual same-day discharge, but ultimately, again, choice is what works for you and your institution. Again, if choosing neuraxial anesthesia, really consider your short-acting local anesthetics like bupivacaine and chloroprocaine. But ultimately, we need some more RCTs to effective anesthesia on type on outcomes, especially in the hip fracture patients, especially in our sickest patients, because I think that we have some good studies. I think we really need more to really make a good conclusion on what we can recommend to our patients. So that's it for me. Thanks.